And welcome everybody to Oncology Grand Rounds. Just a reminder that we actually have in-person Grand Rounds now for anybody who wants to come. We're in Botterill Hall, and today we actually have a very good crowd here in person, and I see we have a lot of people on the web as well. So welcome. And today it's my great pleasure to welcome to Queens, to Kingston, Dr. Temidayo Fadelu. Dr. Fadelu is at the Center for Global Health, Division of Population Sciences at Dana-Farber Cancer Institute. He's an instructor in medicine at Harvard Medical School, and we were fortunate enough to have Dayo here yesterday for Global Oncology Rounds, and now really looking forward to his talk today. So thanks, Dayo, for coming from Boston, and really looking forward to your talk.
Thank you. Okay, thank you, everyone. Thanks for the invitation, and it's glad to speak with you again today. So here's the topic of what I'll be talking about: equity in global oncology, global oncology care and research, lessons from Rwanda and Haiti. Nice. Yes.
There we go.
Oh yeah. Okay, we found it now. Thank you. Okay, excellent. So here's the outline of the talk today. We'll do a brief overview of global cancer disparities, just to give you a sense of the magnitude of the problem. I'll go over a few slides giving you an overview of the programs we work with in Rwanda and in Haiti. We'll talk about geographic access to cancer care and the implications for equity. Also talk about research and research authorship and equity in global oncology, and a summary slide. So here are my disclosures. I receive some institutional research funding from CGCM. So here is a graph that shows you the burden of cancer globally. So this gives you a sense of the number of cancer cases worldwide and how that's distributed amongst the different regions. So, most of the cancers occur in Asia, which sort of mirrors the population of the world. I showed this or something similar to this yesterday. Over the next 20 years, there's an expectation that the number of cancer cases will rise worldwide, both incidence and death. But what I sort of want to highlight here is most of this increase is going to occur in low resource settings. For example, looking at this graph, there will be an over 90% increase in mortality from cancers broadly within Africa over the next 20 years. Here is also a map of the world showing you the leading cause of cancer death in women in all the countries worldwide. So the blue indicates lung cancer, pink indicates breast cancer, and the orange indicates cervical cancer. Overall, breast cancer is the leading cause of mortality worldwide. And as you can see, in countries like the US and Europe and other high-income countries, in women, the leading cause of cancer mortality is lung cancer, while in places in Africa and in other low-resource settings, it's still cervical cancer. This gives you an indication of partly resources that are available to treat cancer in these places, because as you know, cervical cancer is quite preventable, either preventable by early detection or the HPV vaccination. And also breast cancer is also quite treatable, especially if it's caught on time. So as you can see, as countries transition from low income to high income, you're sort of left with cancers that have worse prognosis, like lung cancer being the significant cause of cancer mortality. So here is a graph from a paper from actually 2009. I show it to you because things have really not changed since then. But this gives you a sense of the mortality to incidence ratio for different cancers segregated by the income level of the country. So all the way on the side are low income countries and all the way on the side are high income countries. So the higher the mortality to incidence ratio gives you the sense of how poor the outcomes are. So across the board, the much higher mortality to incidence ratios for cancers in low income countries compared to high income countries. And the difference can be quite significant. So for example, for cancers like cervical cancer, for cancers like breast cancer, they're quite curable if you have the appropriate resources. Or in low resource settings or low income countries, a lot of people are still dying from these cancers. So drilling down specifically to breast cancer and comparing, for example, the US and Rwanda, the mortality to incidence ratio for breast cancer is 14% in the US. So the number of cases of breast cancer that year versus the number of people who died from breast cancer that year. While in places like Rwanda, it's 50%, and in some other countries, it's even higher. Obviously, differences in stage of distribution at presentation contribute to this. So in the US, only 6% of women have metastatic breast cancer at diagnosis, while in Rwanda, that number is 35% and higher in some other places. However, there are other contributors to this as well. So poor access to treatment and social inequities are also significant contributors to these disparities. So I'll sort of shift gears and tell you about the Center for Global Cancer Medicine at Dana-Farber, and then give you some historical background on the two programs that we work with. So the Center for Global Cancer Medicine was established in 2012 as a part of a larger global health delivery partnership, which was a partnership between Brigham and Women's Hospital, Harvard Medical School, as well as Partners in Health. And some of you might be familiar with Partners in Health. It's a nonprofit that is based in Boston that supports the delivery of care in a variety of low-resource settings around the world, really with a mission of bringing good health care to places that have incredibly limited resources, usually in conjunction or in collaboration with local partners. So Partners in Health around 2012 decided to pursue oncology care delivery in Rwanda and in Haiti, and that's how the relationship with Dana-Farber occurred. There are also other academic partners, which are on the slide. So here's a picture of the two sites, Rwanda and Haiti. And I'll talk a little bit more about the program in Haiti and just give you a little bit of background about Haiti. So Haiti is a country of 11 million people. It's quite a lowly resourced country. So if you rank the country by GDP worldwide, they stand at number 172. The quote unquote poorest country in the Western Hemisphere, and I think Haiti has been in the news of late, so I think some of you might be familiar with. There are lots of challenges in Haiti right now, political challenges, natural disasters. So it just gives you a sense of what the fact that it is in fact a challenging country, not just economically, but challenging in general. So here's a summary. So these numbers are adapted from the Global Can data set that is put together by IR. I should mention though, many of in places like Haiti, where there are no cancer registries, many of those numbers are based on estimations. So they're not necessarily based on actual numbers. But nonetheless, the estimated number of new cancer cases is about 12,000 per year, with an estimated number of about 9,000 dying from cancer. So that gives you a mortality to incidence ratio of 75%. So I'm just giving you a sense of the magnitude of the problem in a place like Haiti. So here are the, as of today, cancer care facilities in Haiti. So there's one public cancer facility, and that's the one I was telling you about, Mirabelle Hospital, and the acronym we use is HUM. There are 4 private clinics, and there's also one pediatric oncology center. So on this map, the star is the hospital I was telling you about. That's the capital. And you can see most of the other facilities are centralized around the capital. The challenges with the private clinics obviously are the fact that you have to pay out of pocket. So it's not necessarily something that is accessible to most individuals who live in Haiti. So the HUM Cancer Program started in 2011, led by an internist, Dr. Ruth Damuse. So she had gotten some additional training in hematology, but not a formal fellowship. And you'll hear that theme as I as I go through the talks today. The theme of task shifting and utilizing people who might not necessarily have been trained in oncology to deliver care. So the center moved to where it currently is in 2015. And so the hospital I showed you was a hospital that was constructed right shortly after the major earthquake that happened in 2010. It's a teaching hospital. It's a 300-bed hospital that also does host a variety of residency programs. So residents started rotating through the oncology unit. And in 2015, a multidisciplinary oncology clinic was started in conjunction with a dedicated oncologic surgeon. In the past, there were just general surgeons, but no one was really dedicated to oncology. And in 2018, a new wing of the hospital was renovated and specifically dedicated to treating oncology patients. And I should mention, even amongst all of these challenges, just recently this year, they were able to start a Gyn Oncology Fellowship, and this was something that was done remotely in collaboration with partners in Boston at MGH to train fellows who are physically based in Haiti. So gives you this next slide gives you a sense of the human resources that are available, and also a sense of the numbers of cases or consultations that they see at the center. So there are 3 internists who are dedicated to the program, 1 surgeon, as I mentioned, and a pediatrician, a team of nurses, psychologists, social worker, as well as a palliative care team who is made up of a family physician as well as some nurses. Here are the number of cases of consultations that they see on a yearly basis, and quite significant numbers, and numbers that have essentially risen from year to year. So I'll give you just talk a little bit, just a couple of slides on the Rwanda program. Dr. Fadelu, who is one of yours, will be doing a presentation in a couple of weeks. So I won't steal his thunder. I'll just have a few slides on this. So the Rwanda program, so similar to Haiti, Rwanda is a low resource setting, and Rwanda has a very similar population size, also similar land size to Haiti. So in 2012, when the cancer program was about to start, there was only 1 trained clinical oncologist in the entire country of Rwanda, and limited resources with regards to what was dedicated to oncology care. There was only 8 medications on the national formulary that had any form of oncologic indication, no radiation facility, and minimal resources with regards to pathology. So around that time, the Ministry of Health convened a cancer control planning committee to come up with strategies for a national plan for what to do with regards to cancer. And these were some of the major priorities that the government decided on. So one was HPV vaccination. I think there was a question about this yesterday. So Rwanda has actually been quite successful and massive HPV vaccination campaigns, probably the most successful country in the world from that perspective, but also decided on formulating cancer treatment programs and deciding on priority cancers. So not necessarily tackling all cancers, but based on the prevalence of the cancer and how potentially treatable it is. They decided on what cancers to focus on. And there was also a focus on training and capacity building, which included local training and capacity building, as well as sending Rwandans outside of the country to get trained. Fidel can tell you a little bit more about that when he speaks in a couple of weeks. And as part of this mission was the designation of Butaro Hospital as the Cancer Center of Excellence to start treating patients with cancer. The two programs that I'm talking about, the program in Haiti and Rwanda, are supported by Partners in Health, as I mentioned. And I wanted to give you sort of a sense of, PIH's philosophy and driving mission for how they work with not just in oncology, but in the care delivery programs that they engage with. And they have this, I guess, mantra they call the 5 S's, which is staff, space, systems, and social support. And all of these things sort of are essential and are sort of working in an interrelated fashion in order to make care delivery possible. And these are also some guiding principles for how they've engaged with oncology care in both places. So some key elements of the oncology program, as I mentioned, the idea of task shifting. So the idea that in many low resource settings with limited trained professionals, you sort of have to really think outside of the box with regards to who delivers the care and what type of support people can get in order to deliver care. So task shifting, not just with physicians, but also with nurses and pharmacists and sort of across the board with regards to what's possible to deliver care appropriately. Partnerships, so partnering not just with the Center for Global Cancer Medicine at Dana-Farber, but partnering with a variety of people in order to support care delivery. The oncology programs are embedded within public hospitals. So Atrium is a public hospital, Butaro Hospital is a public hospital, which not only, in my mind, is a way to ensure buy-in from local authorities, but also potential sustainability of programs in the long run. The priorities are really driven by the local needs. The oncology services at these facilities do not cost, there's no direct cost to the patient for at least the oncology dedicated services that patients are getting. Also the idea of collecting data in a very consistent way in order to monitor and see how things are actually doing, what type of change, what type of progress and what type of change is actually happening at these places. I showed this schematic yesterday as well. I just want to highlight this again. That's the social support portion of the diagram I showed you earlier. So the idea of really trying to evaluate social determinants of health and addressing them in a systematic way is also quite essential to the possibility of delivering oncology care in low resource settings. So for example, assessing challenges with transportation, for example, providing food packages for patients, not just the patients themselves, but also for their families, for what they might potentially need. Patient education, for example, is also one thing. So all of these elements that might impact the way patients engage with care, addressing those in a very systematic way. So I'll talk some about some of the other activities that the Center for Global Cancer Medicine does in conjunction with Partners in Health. So we support clinical care. So in order to have task shifting happen appropriately, you sort of need protocols. So the center supports the development of context-specific protocols that get revised and reevaluated on a routine basis. Also, weekly tumor boards. So we'd actually been doing Zoom way before the world discovered Zoom, because Zoom was the way we were engaging with our partners. The use of electronic medical records, which might seem like a no-brainer. I'm talking to a crowd like this, but in many low resource settings, electronic medical records are not the norm. Specifically, when you sort of think about chemotherapy administration, chemotherapy delivery, and the potential for errors occurring, electronic medical records can in fact be quite helpful. Also supporting the implementation of pathology services and other types of diagnostic services. I wouldn't delve into that much other than what I've mentioned. Also, other activities include capacity building, nursing education, pathology technician education, physician education, and long-term mentorship. Also, teaching of technicians on to do biopsies, teaching nurses to do biopsies and ultrasounds. All of these sort of, under the main rubric, as I mentioned, of helping people sort of function beyond what you consider the routine tasks. And all of these are important aspects of being able to do things in a low resource setting. The next few slides will be sort of a review of a few research activities. This is by no way comprehensive, but just a few examples to give you a sense of the type of things we're doing. And then I will sort of delve into the aspect that looks at geospatial access to care equity. So I went through this example yesterday, and I want to highlight a slightly different place of what compared to what I highlighted yesterday. So this was a project that we did understanding breast cancer care delays, and where I want us to focus on is this part of care continuum delays. So this is the breast cancer treatment pathway from when a patient discovers a breast cancer symptom all the way to survivorship. Delays can happen in multiple parts of this pathway, but we were sort of interested in what happens after the patient has been seen at or has been given a diagnosis of cancer. So this was a mixed method study that included qualitative interviews, a quantitative survey, as well as a review of the medical records. And what we were interested in, or the domains we were interested in, were in disease treatment and knowledge, socioeconomic status, treatment toxicity. We also delved into the concept of the idea around things around transportation, because we recognize that's a significant burden for these patients. And I'll show you in the next few slides, you'll see why. And also communication and technology preferences, thinking towards potential solutions that we might want to implement in the future. So as I discussed yesterday, we categorized the barriers. So this is a summary of the results from the survey. We categorized the barriers into different three main domains. I just want to show you the larger categories. So challenges that are inherent to cancer treatments, which we obviously can't really change. There were some challenges that were associated with family and social support challenges. And then the last category was what we classified as challenges that were potentially amenable to health system interventions. So for example, poor understanding of treatments, forgetting of appointments, side effects, transportation costs, and all of these other things, which are things that potentially could be changed over time or could be intervened upon. This is also a slide I showed yesterday, so specifically summarizing the results of the transportation barriers, and the idea or the sense that patients are not necessarily driving in their own cars. Most patients are taking public transportation. The amount of time it takes, so the median travel time, one-way travel time from the patient's home to the cancer center was 7 hours, and also the significant cost of the trip. Although many patients were already receiving financial support, this study was an argument for even more financial support to support transportation costs. The part that I want to highlight, which we didn't delve into yesterday, were the themes that came out of the patient interviews. And here are sort of the themes and the way we categorize them. So insufficient support from the hospital, transportation challenges, and then I'll give you a couple of quotes from patients for the last three. So fears and misconception, abandonment by spouses and family members, as well as community isolation. So here is a quote from one of the patients. So I came out scared. I felt like when a cancer patient undergoes surgery, he dies immediately. I had a feeling like once you undergo a lumpectomy, you will die. So I'll give you another quote. Some said that I was poisoned. Others said that I would not recover from my illness. So I should mention, so the patients who were included in the study were patients who had non-metastatic breast cancer who were undergoing curative intense treatment. So these were patients who, with the appropriate type of surgery and systemic therapy would actually most likely do fine from their cancer treatment. Another quote, which was under this theme of abandonment by spouses and family. So this is a woman, so up to now, our relationship has changed. So she was talking about her husband. He gave up on me because I was sick and spent most of my time seeking medical attention. I know about love. It flourishes during good times. Only very few people persevere in love during the bad times, and I was not among the lucky ones. And here's another quote, which sort of embodies the idea of community isolation. So the worst thing is that people traumatize us. Neighbors are pointing fingers at us, saying, "Look at that woman, her breast has been removed." So there are several other quotes. I just picked these ones, so just to give you a sense of the type of things patients are undergoing. These things are not necessarily unique to the Rwandan context. Nonetheless, here are things that patients undergo in many similar low-resource settings. So I'll change gears and give you a couple of examples of some work we've done on geographic access and equity. So here's a recent publication from earlier this year, which was exploring equitable access to tertiary cancer care in Rwanda. So the idea was to describe national level access and variation in Rwanda by region, poverty status, and rural/urban status, and to sort of think about what we could potentially propose to policymakers as a way of potentially expanding care. That's my water. Yeah, sorry. Thank you. Got it after all. So here is a map of Rwanda. And as of today, although there are challenges in defining exactly what a tertiary cancer facility is, but as of today, we'll say we have 2 tertiary cancer facilities in Rwanda. So Butaro Hospital is indicated by 1 on the map, and Rwanda Cancer Center, which was opened in 2020, is indicated by 2 on the map. And this was an analysis looking at the road network and using geospatial techniques to estimate how long it will take people to get to cancer care. So the blue on the map means you're closest to the cancer facility, and the farther away you are, that gives you the different colors. So just looking visually from a high level place, you can see that most of the country is greater than 2 hours from cancer care. So I should say, the way we did this estimation is the assumption is patients are going directly from their home to the cancer facility in something like a vehicle of some sort. So the reality is even worse than this, as I told you, that patients were traveling 7 hours. So I'll say probably multiply these numbers by 2 or so, and that sort of gives you a sense of how long it takes from across the country. So we calculated or estimated what proportion of people living in the different provinces had access within a variety of time thresholds. So looking at a travel threshold of 1 hour, 2 hours, and 4 hours, what proportion of people living in Eastern Province, Kigali, and Northern Province, etc., and how long, what proportion of people in those areas fell within those thresholds. So just in summary, you can see that Kigali City had relatively good access across the board. Most people in Kigali were within an hour of the cancer facility, while some places, for example, in the Western and Southern provinces had pretty poor access. And we also calculated the median time. So this is population level, not necessarily based on a specific patient. And that sort of gives you a sense of the median time someone living in that province will take to get to cancer care. And as you can see, someone living in the Western province, that's a lot of minutes to get to cancer care. We did a similar analysis. So looking at access by the level of poverty in the different units. So for example, going from an area with very low poverty rates to an area with very high poverty rate. The way this was categorized was based on this percentages of poverty, as you can see. So less than 20%, 20 to 30%, all the way to like at areas that have over 50% poverty rate. Doing something similar, looking within different thresholds of time, what proportion of people who fell into those categories had access to a cancer care, tertiary cancer care facility. To summarize this, the more folks who are living in poorer areas had worse access. So this is not necessarily something we did not expect, but this was something that we were able to quantify in this analysis. Similarly, looked at the median time it will take people. So we sort of proposed that doing geospatial analysis like this could potentially be a way of the country deciding where next to put a cancer center. In Rwanda at the moment, there are 7 or 6 what we'll consider tertiary or referral level type hospitals across the country. We did an analysis looking at if all of those centers had some sort of cancer care facility, what type of impacts could that potentially have on access going forward. Although we recognize that this is not going to happen overnight, it could be a way of a country deciding, okay, where has the least access and where should we put a facility and how would this potentially impact access going forward. So based on this analysis of, if all of these new places also had cancer care, how would that potentially impact access? So just bring in short, obviously access improves everywhere, but most especially in the places that had the most limited access before. So going from 0% of people having access within 1 hour to 20% of people in the Western province having access within 1 hour. Across the board, as you can see, the median time also goes down pretty significantly. And a similar analysis also looking at access by poverty level, median time goes down pretty dramatically across the board, and most of the benefit occurs in people who are living in areas with the highest poverty level. So just given a sense that the location of where a facility is placed can in fact impact that's a vital, the location of facilities is quite vital when you're sort of thinking about equity and who is actually accessing those facilities, and are the people who are lowest in society able to access those facilities. Okay, so A similar analysis we also did. This is now beyond Rwanda, looking at the whole of sub-Saharan Africa. So we're talking about this right before we started, or right before I started this talk, that radiotherapy, which is a critical aspect of cancer care, radiotherapy facilities we know are in short supply in many low-resource settings across sub-Saharan Africa, as well as in many other places. However, many of the conversations that have happened around radiotherapy are typically focused on how many machines are there. We wanted to go a little bit beyond that, recognizing that the number of machines is one part of a much larger problem. Where the machines are placed is also important. So you could have 5 machines in one specific location and then nothing in other parts of that country. So this analysis was a geographic analysis looking at accessibility to radiotherapy amongst countries in sub-Saharan Africa. And I'll show you a map of what we found. So we essentially looked at a database of all the radiotherapy facilities, placed them on the map, and did a similar analysis looking at the road network, looking at where individuals were living, and we're estimating exactly how long it would take people to get to radiotherapy across the whole of sub-Saharan Africa. So a couple of things I should mention with this analysis was we recognize that individuals can and do in fact travel across country. So we didn't necessarily consider country boundaries as a limitation. So if someone was living in a nearby country, which was close to a radiotherapy facility in a different country, we allowed them the possibility of being able to travel. So in summary, this results show that 24% of sub-Saharan, only 24% of sub-Saharan Africans can access radiotherapy within 2 hours. So we chose a 2-hour threshold. We sort of debated what threshold we should choose. So we did look at 1-hour thresholds and 4-hour thresholds, and decided perhaps a 2-hour threshold made some sense, because 2-hour thresholds have been used for other studies that have looked at accessibility to emergency services or accessibility to surgical services in the Africa region. But nonetheless, a very small proportion of people have adequate access time-wise. So the countries that had the best geographic access were Rwanda and South Africa. So I should mention, smaller countries have a little bit of a benefit here, because if you're a relatively small country and your radiotherapy facility is right in the middle of the country, obviously you will have good geographic access. And then, so 21 countries had no access at all within 2 hours. I'll show you a couple of additional stuff. Okay, so in this analysis, we did in fact rank countries based on what we call the availability measures, which is number of machines per population, and we ranked by number of machines per number of cases of cancer. And we also did a similar ranking of accessibility, geographic accessibility based on our 2-hour threshold. So I should mention, just high-level summary here is, most of the time there was in fact, a correlation or an association between places that had machines and accessibility within 2 hours. However, it wasn't perfect. So hence the point of what we were trying to make with this analysis, that you can't just look at availability, you also have to consider exactly where those machines are based. So we came up with what we called an overall ranking, which took into consideration those 2 perspectives. So I should mention that the countries in red are countries that were high or in the top 10 for geographic access, but did not rank in the top 10 when it came to availability access. While the countries in orange were countries that ranked higher in availability access, but not high in geographic access, showing that the location of the machines in fact is important and does play a role. So this paper is going to be published in the Red Journal, and it'll be out within like 1 to 2 weeks. So this is the last part of the talk, and I think we're doing good on time. So we've sort of talked about ideas of, ideas around what it means to have cancer care services in low resource settings. And we've talked a little bit about equity and access. Here we're sort of changing gears to talk about who in fact tells the story, and essentially equity in research and equity in publication. And Fidel was involved in this analysis that we did. So we were looking at within the global oncology literature, specifically within the Journal of Global Oncology, what type of papers get published there? What is the research focused on? What countries are people from who are doing the research? And here, what I'll show you is that, as the mission of the global health world is to elevate, care and research within low resource settings, they do, in fact, this journal does in fact do that, meaning that most of the publications, so more than 50% of the publications were from low-income settings and low-middle-income settings, and a significant proportion were also from upper-middle-income countries. However, when you look at the authorship of who in fact is writing about these things and who in fact is studying these things, you see that most of the authors are from high-income countries. We did look at this on a regional level as well, which I will show you on the next slide. So this is a table. I'll walk you through this really quickly. So we were looking at, similarly, where was the study from and where are the authors from, but looking at this regionally. So if the first author region and the study region coincide, you sort of are in the middle right here. So if you sort of like follow the middle all the way down, you can see that in most of the regions, the first author region and the study region coincided relatively, not necessarily perfectly, but that's, most of the people who were first authors were from the exact same region. The only place in which this does not happen is in Sub-Saharan Africa. And in Sub-Saharan Africa, there are in fact more first authors from North America than there were first authors from Sub-Saharan Africa. We did a similar analysis looking at last authors as well, and something similar was shown there as well. And so I bring this up as a way of us being mindful, and this is also a lesson for me. So in engagements in global oncology, part of some things we should certainly keep in mind is not just equity in creating equity for care access, but also opportunities and ways of in fact empowering people who are in the local places to take ownership and take leadership on research publications as well. And the last thing I would show you data-wise is we also looked at gender equity, and this was certainly way starker than we anticipated it would be. So looking at, so this is for the last authors, but it was quite similar looking at first authors as well. So looking at the breakdown in gender based on where the authors were from, and in authors from low-income countries, men made up the vast majority of the authors. And while there's a little bit more equity as you go within the income level, overall and in aggregate, female authors were in the minority. So not just thinking about empowering local investigators, but thinking about who is in fact who in this place are these places that we are in fact empowering. How can we improve these numbers or engage in a much more significant way? So that's really all I have. So just a last summary slide. So we've discussed approaches to cancer care delivery in low resource settings. We've highlighted the importance of partnerships, addressing global cancer disparities, reviewed the role of geographic access and given you a couple of examples of how we can take that into account when we're thinking about equity in cancer care, and also discuss the need to foster equity in research and in publications. So my acknowledgements, lots of people to thank, the Center for Global Cancer Medicine, partners in health, collaborators in Haiti and in Rwanda, mentors, as well as folks who provide funding for some of my work. So thank you.
So, Dio, thank you so much. You know, I've had a chance now the last couple of days to see your work and get a better understanding of it, and just incredible work. Very powerful, both in terms of answering important questions. Really love that you're doing mixed methods work and looking at the qualitative aspects. Some of those quotes are incredibly powerful. And I think, you know, something that we're very mindful of as well is linking that work to impact and changing policy. So amazing. Thanks for sharing that work, and thank you for the work that you do. It's really amazing. So I'm going to start just with questions here in the in Botterill Hall, and then also I'm happy to take questions from folks on the internet as well.
Thanks so much. That was great. It struck me as you were going along that Rwanda has really put together a forward-thinking vision of how to approach their cancer control in the next 15 years, and has embedded research and geographical, spatial questions, and really a whole slew of really important issues. So I guess my question is, to what extent is Rwanda acting as a leader within Africa to sort of model how other countries in the region might be able to apply these sort of methods and in order to develop their own systems?
Yeah, that's a great question. So, you know, the story I'm telling obviously is about Rwanda, and there are different countries have addressed things in different ways, and some countries have sort of taken quite a similar approach to the way Rwanda has done things. So I'll say, it's sort of emphasizing the need for having a national plan and a national agency for that plan. Not all countries in Africa have done that, but I think certainly Rwanda is a leader in that type of strategy. And I know, some other countries that have done something similar. So in Kenya, in Tanzania, they've also had national meetings and decided, okay, this is exactly what we'll include in our national cancer control plan. Here are the things we want to hit. Here's what we feel is a path to getting there, and also reevaluation of that over time. Yeah, so certainly I think Rwanda has been a leader in a variety of ways. And the HPV vaccine story, I think that's also pretty incredible in how they've been able to lead that way as well.
Okay, I just on the online, just put up your hand, or I'll keep an eye out. Dio, yesterday I was gonna ask you about linking the geospatial work in Rwanda to policy, and you told us today about what you're doing there. Have you had any thoughts yet about how you're going to link the geospatial work on access to radiation machines in sub-Saharan Africa to policy, or have you started to think about how you're going to share that, or how you're going to use that to influence policy?
Yeah, that's a great question. So what spurred us to do that project is because we've been seeing multiple papers like over the past 20 years that said the exact same thing, which was there's not enough radiation machines, there's not enough radiation machines. So so that's what spurred this this analysis. I would say that we presented this work at the World Cancer Congress a couple of weeks ago, and certainly had a lot of questions and people who were interested. Obviously, geographic access is also not the entire story, because as we were saying, are the machines working? When are they not working? Are there enough staff? So one of the ideas that we have, and we're sort of thinking about how to actualize, is doing something that is a little bit more longitudinal over time and doing routine assessments, say over a couple of years, to get some of these measures. And folks from the from IAEA are in fact interested in saying, okay, how can we help? How can we help assist countries make their radiation facilities work a little bit better? So yeah, so I think the next step will be collecting some of these other measures, and hopefully that people are able to see that and come up with ideas on how they can, in fact, actualize making things better.
Great. And we're going to follow that closely and keep in touch with that because we're sharing some of the issues around that. Nazik, you have a question, go ahead.
Thanks, Dayo. That was amazing. I was wondering, when we look at the pattern of partnerships, and we notice that some countries within partnerships, there's some inequity with some countries that have more partnerships compared to other countries in Africa. And of course, we have always discussed this, that the only way to do that is to share the knowledge, share this experience among African countries. So what are your thoughts as to, is it the role of awartic? Is it, how do we make, and that ties in with Brooke's question, how do we make sure that all of this experience is shared, and how do we bring this kind of, work and analysis to areas that do not have access to such partnerships?
Yeah, that's a very good question, Nazik. Thank you. So I definitely think an organization like AORDIC, which is the African Organization of Research and Training in Cancer, I think AORDIC plays a very central role and a forum for people to learn about what others are doing. Personally, for me, it's actually been quite helpful because I've learned a lot. Personally, it's been helpful because I've learned. That's okay. I've learned a lot about what other folks are doing, and some of the projects, for example, the Gene Expert project I mentioned yesterday. Part of that. Sorry.
I got it. Sorry, just
I'm making a mess here.
Yeah. Okay, we'll take care of it later.
Yeah, part of the idea for that project came from meeting folks at AORDIC. I think other forums for people interacting are collaborations amongst ministries of health. So I know the WHO Afro region does put out policies and engage with ministries of health across the region. So I think that's certainly another way. I know there have been some work around not just integrating things within oncology, but integrating amongst other NCDs as well, and which has been led by WHO Afro. Yes, those are two examples of possibilities of collaboration that come to mind for how people can sort of learn from one another for what's actually happening in the region.
Thanks, great question, and thanks, Tayo. Nav, go ahead.
Thank you very much for the great question. So just one question about, have you guys thought about looking at like access to essential care? Like, as you said, metastatic is kind of quite prevalent in the region, and then there are a lot of people who are not able to access the services upfront, but like the way how public health is engaged in making sure HPV vaccine and all of the programs are running, but like access to palliative care or even like basic care related to cancer.
Yes. Yes, absolutely. There was a slide I was going to add, which I ended up taking out because of time, which sort of shows you the different levels of the healthcare, like a pyramid of the different levels of the healthcare system in a place like Rwanda, and what's available and what's accessible at each level. So, starting from the health centers to the district hospitals, to the provincial hospitals, to the national hospitals. Part of the cancer control plan in many countries, I'm familiar with the one in Rwanda, sort of has recommendations for what needs to be available in each of those settings. So, for example, palliative care, the idea is that it's available in every district hospital with some type of care that is also available at the health centers. That's the goal, not to say that that's what's happening now, but there is, in fact, when countries make the national control plans, they're encouraged to make those type of assessments. Does that answer your question? Yeah.
Laura.
In your gender analysis, you mentioned at first and last authors, but very few looked at authorship in general.
Yeah.
And I guess really I'm wondering if you think it's more of an issue of women being offered leadership positions on authorship teams, or if it's more of an issue of engaging in research in general.
Yeah, that's a great question. And the paper is published already, so you'll be able to actually see it in more detail. So yes, we looked at authorship. I gave you a snapshot. We looked at authorship in general. Women are underrepresented across the board. Predominantly underrepresented as last authors. There's this idea of being stuck in the middle, which happens not just for female authors, but also for authors from low resource settings. So they're more represented in the middle, but least represented as last authors, less so as first authors. Interestingly, in the gender analysis, in high income countries, we looked at a trend over time, and there are in fact more female authors over time recently compared to before. Yeah, so I'll send you the paper, link to the paper. You can assess, you can look at it in detail. Yeah.
So I don't see any further questions here, and no more hands on the line. Great presentation, great discussion. Thanks again so much for coming. I look forward actually to working together, because I see so many of our interests aligned. So I hope this will be the start of ongoing collaborations together, Diane. Thank you.
I hope so too. Yeah.
Yeah.
Thank you. Thank you very much.
That's okay.